Honorable Chairpersons, respected audience, and other participants, a very good morning to you all. My topic is, as you know, home and ambulatory blood pressure monitoring. This is our organization in Chittagong. I have no conflict of interest. So all of us know hypertension is number one in some areas. It is number one cause of visit to physicians in adult primary practice. It's most common silent cardiovascular risk factors. It accounts for most drug prescriptions and the number one attributable risk factor for death worldwide. So hypertension is common, easily detectable and treatable condition. There are three ways to detect it. Number one is conventional auscultatory office measurement. Secondly, home blood pressure measurement, SBPM. Third one is ambulatory blood pressure monitoring, ABPM. Conventional methods for diagnosis is office blood pressure measurement, but it cannot give idea about blood pressure variability day and night. It cannot assess the effects of antihypertensive drugs and blood pressure on blood pressure variability. And obviously it is inaccurate in white coat hypertension and masked hypertension. Home monitoring is self-monitoring system using validated oscilloscopic device measurement done in home setting, which is more relaxed environment compared to doctor's office. 2 readings in the morning, 2 readings in the evening for 3 consecutive days, and the readings are averaged. If blood pressure is 135/85 or more, we label it as hypertension. Measurements by self improves drug compliance and control rate. But problem is it can be repeated, it can be repeated over long periods to assess blood pressure variability. And it can identify white coat and masked hypertension as that of ambulatory monitoring. But the problem is we can get only static blood pressure measurement. No nocturnal reading is possible. Monitor should be checked in the office for accuracy, and patient, if become obsessive in measurement, it should be abandoned. Ambulatory monitoring is the gold standard for measurement of management of hypertension. It provides automated measurement of blood pressure during 24 hours period while the patient are engaged in their usual activities, including sleep. Both American and European guidelines recommend it. Greater number of readings, absence of digital preference and observational bias, and reduction of white coat effect contributes to its predictive accuracy. It predicts fatal and non-fatal MI and stroke better than office measurement. You see here the ambulatory measurement of systolic blood pressure is more predictive of 5-year risk of cardiovascular death compared to clinic measurement. So the technique is, machine is automated and battery operated, blood pressure cuff wrapped around upper limb, and the arm is kept at heart level, as all of us know it. Blood pressure measured in 15 to 30 minute interval, no heavy meal, no bath, no shower, no swimming during monitor. All information is kept in record, including sleep and awake time, any symptom arrival, and medication taken. A successful APVM should include at least 20 valid awake and 7 valid sleep measurements. So this is the instrumental aspect. You see here that the normal reference value for ambulatory monitoring compared with the normal value of ambulatory monitoring. And you see that the optimal value is a bit lower than normal. And 24 hours daytime, nighttime, obviously nighttime blood pressure recording is lower. This is higher and this is in between. This is categories of hypertension on ambulatory monitoring compared with home and office monitoring. The first one is ambulatory, and you see that the American guideline sets the threshold to a bit lower values compared to European guidelines. And here ambulatory monitoring values are lower, this is in between, and office measurement is a bit higher. And this is categories of hypertension in ambulatory monitoring, 24 hours, awake and sleep time. Again here, Americans set their values to a bit lower threshold. So the indication of ambulatory monitoring is white coat hypertension detection, marked hypertension detection, labile hypertension, nocturnal hypertension with dipping status, when confusion arises whether to start antihypertensive drugs and for resistant hypertension. Now, white coat hypertension. White coat hypertension is due to transient adrenergic response to blood pressure measurement in physician's office. Suppose a daytime ambulatory recording is less than 130/80 millimeter mercury but there is no target organ damage, but there is persistently elevated office blood pressure. So this situation is definitely a case of white coat hypertension. Ambulatory monitoring eliminates over-treatment in up to 30% of cases. White coat aggravation, there is a condition called white coat aggravation if the this is due to also white coat sympathetic overactivity, and if the office reading is normal and the out of office reading is a bit higher and there is white coat aggravation, it needs definitely treatment. So white coat actually introduced as a sign of calmness and soothing for the particular patient. But sometimes it becomes counterproductive, resulting in raised blood pressure in doctor's office. So there is another condition called marked hypertension, but this is not marks induced. We are all wearing masks for last few years. Office reading here underestimates out of office reading. Sympathetic overactivity in daily life, home stress, job stress, tobacco use, alcohol use, all responsible for this condition. It increases cardiovascular risk despite normal office blood pressure reading. The documentation prevents under-treatment in more than 30% of cases. See the scenario, these are loving couple, but this thing seldom happens. If this happens, what will be the ambulatory reading? That particular person has normal office blood pressure. As soon as he comes to his house, blood pressure shoots up. So this is marked hypertension. Also at night when he sleeps, the blood pressure is to higher level, so this is nocturnal hypertension. So nocturnal hypertension and dipping, blood pressure normally dips during sleep at night and increases sharply on waking. Ambulatory pressure recording reveals a blunted or abolished overnight dipping. It is determined by comparing sleep and daytime blood pressure. Non-dippers have higher left ventricular hypertrophy. So this is dipping, this is non-dipper. If blood pressure lowering is 0 to 9, it should be from 10 to 20%. And if it is less than 0, it is reverse dipping. So let us see this tracings of ambulatory monitoring. This is more than 15%, so this is normal. This is also normal, there is dipping at night. But here there is no dipping, rather there is no variation of recording. So this is positive ambulatory recording. Here also there is no variation and there is reverse dipping at night. Also there is a source of blood pressure raised blood pressure in the morning. So the advantage is abundant information can be get from ambulatory recording. Readings are in real time, night time blood pressure recording may be possible. Prognostic evidence is stronger. But the limitation is limited availability of device, night, high cost and disturbance of recording at night. These are all problems with ambulatory recording. So this is comparison between these two. Ambulatory recording, non-self, here it is self, compared to home recording, real time, not real time. Intervals of daily activity here occurs, does not occur. 24 hours blood pressure recording may be possible, not possible. Measurement error less, here more. White coat, marked hypertension may be possible to read in both the conditions. But nocturnal hypertension detection is only possible in ambulatory monitoring. So this is all about comparison. So the conclusion is both home and ambulatory blood pressure are extremely useful for blood pressure measurement and management. Ambulatory recording is the state-of-art recording system for blood pressure measurement. And home monitoring should be practiced more and more to increase the compliance of the patient. But in future, the instrument combining the both facilities may be available for further control and increasing the compliance of patients. So thank you all.